Hi, this is Dr. Michael Brisman. I'm a neurosurgeon from Long Island, New York. I'm part of a group of neurosurgeons called NSPC Brain and Spine Surgery, and I wanted to talk to you about pituitary tumors. The pituitary gland, which is sort of the part of the brain that's sort of behind the eyes, behind the nose, in the middle, is a very small gland that is called the master gland because it produces hormones that tells all the other glands what to do. So it sends hormones out to the adrenal gland, for example, the thyroid gland, other glands, to tell them when to be active, how active to be. The pituitary gland can sometimes have little tumors in it. These tumors are almost always benign, and these have been called pituitary adenomas. More recently, some people are calling them pit nets, but they're benign tumors. Usually, these tumors are very, very tiny and don't cause any problems. And more, as we do MRIs on people, and MRIs are more available, we're finding that lots and lots of people have these. And autopsy studies have suggested that maybe as many as 25% of people have some very, very tiny, benign pituitary adenoma. So just because you have one of these, that doesn't mean there's anything bad going on. The pituitary adenomas, the benign tumors, can be categorized into two subtypes. Subtype 1 does not produce any hormones, and subtype 2 does produce hormones. So one of the ways we evaluate someone with a pituitary adenoma, one way is with an MRI of the brain with intravenous contrast or gadolinium, and the other way is with blood tests where we test people's hormone levels, which may be either too high if the tumor is producing an excess of hormone, or maybe too low if the tumor is compressing the pituitary gland and affecting the normal function of the gland. Also, in some cases, if the tumor is big enough and is compressing the stalk that leads to the pituitary gland, that can cause some modest elevation of one of the pituitary hormones called prolactin. So the reason that these tumors might cause problems is if they get big enough. If they get big enough, the pituitary tumor can grow big enough to start pushing into the optic nerves, the nerves that control vision and sit above the pituitary gland. So that's one of the main issues that can be caused by a pituitary tumor if it gets very big. The other issue is if the hormones are off, because the tumor is either producing too much or too little hormone, or it's either producing too much of a hormone or it's affecting the pituitary gland so the gland doesn't produce enough hormone. So hormone producing tumors are going to be, there's three main categories. One, there's prolactinomas, there's acromegaly cases, and Cushing's. The prolactinomas produce too much prolactin. These tumors are often picked up in young women because they notice that their menstrual periods are off, they can't get pregnant. Sometimes they can note a milky discharge from the breasts. And sometimes these tumors can become very big. The good thing about the prolactinomas, which we can usually tell from the imaging, the MRI, and the blood tests, which show a high prolactin level, the good thing is that these tumors can almost always be managed with medicines. There's a medicine we use called Dostinex or cabergoline that's administered orally. You take a pill twice a week, and it will almost always normalize the prolactin level and cause the tumor to shrink. So it's very rare that we need to operate on a prolactinoma. Now again, there might be some rare cases where the tumor has a sudden big bleed or something, but I mean, those are really rare. The next type of hormone secreting tumor is the acromegaly cases. In acromegaly, which presents in adults, people have too much growth hormone, and we can usually detect this through a blood test where we measure the IGF-1 level. It's a subsequent product of the growth hormone elevation. And people can note increase in size of their hands, their feet, their facial features, It can also cause enlargement of internal organs like the heart or liver, so it can be life-threatening. It can cause arrhythmias. And the treatment of those is going to be usually surgery. The surgery, we operate to remove the tumor. We go through the nostrils now, which is an endoscopic endonasal approach. I usually do it with an ear, nose, and throat doctor. And we'll try to take out the tumor that we can. If the tumor is big, we may probably not going to get all of it out. We may need to use medicines to try to normalize the hormone levels. If the tumor is small, then surgery may be curative. Also, if there's remaining tumor, we can sometimes do very focused radiation on the remainder. The other type of hormone-secreting tumor, the third main type, is Cushing's. In these patients, as a result of the pituitary gland tumor, patients have an excess amount of steroid in their bodies, and they can become Cushingoid, where the faces swell, they can get easy bruising, high blood pressure, diabetes. These people also need to have this elevated steroid issue addressed because it can also cause serious health issues. And usually we will first try to remove the tumor. Again, this is done usually through the nostrils, endonasal, endoscopic. The surgery, by the way, takes about an hour and a half. It's done under general anesthesia. And when people have the surgery, they have to stay overnight in the hospital. If the tumor is not removed in entirety, again, we may do some focused radiation to any remainder, and there are medicines that can be used to try to normalize the steroid in the body, because we don't want people to have too much steroid in the body. That can cause problems. The main category of tumor that we're looking to possibly operate on is going to be the non-secretory type. Again, if these are not too big, we can just watch them. If they are medium size, we may be able to treat them with super focused radiation, outpatient one-day treatment. If they get pretty big and they're pressing on the optic nerves, we may again choose to operate on them through the nose, endoscopic, transsphenoidal. We call it transsphenoidal because we're going through the sphenoid sinus, the airspace that's between the nose and the back of the nose in front of the tumor. Again, any remainder can be treated with super focused radiation. If in any patient the hormone levels are too low, we can replace the hormones. The main hormones that an adult needs are going to be steroid hormone, which can be replaced with hydrocortisone, thyroid hormone, which can be replaced with synthroid, and there's also a hormone that prevents us from urinating too much called desmopressin, or DDAVP, and if that is lacking, that can also be replaced with pills. So there are a lot of good options. Again, these are almost always benign. There's a rare scenario where a pituitary tumor can be cancerous, and those can be hard to treat. We would treat them with surgery, with radiation, with chemotherapy, but those can be hard to treat, but fortunately are very, very rare. Most of the tumors are going to present, as I mentioned, with hormone abnormalities or with vision problems. In rare cases, these tumors can present suddenly with a syndrome called apoplexy, where if the tumor is big enough, it can suddenly cause a little stroke of the pituitary tumor itself, or a bleed, and people can present suddenly with trouble with blurry vision, vision difficulty, trouble moving the eyes, double vision. And if the vision is compromised, we would sometimes operate emergently, but that's not usually the case. Most of the time, these are going to be elective issues. Most of the time, people are going to have long-standing symptoms. And again, in the treatments that we have, which is the medicines, the surgery, which is pretty minimally invasive through the nose, or the super focused outpatient radiation treatment, these are all going to be pretty low risk interventions and are going to give pretty good results. The surgery itself has some small risks of bleeding, vision compromise. There's also a small risk of seeing the cerebrospinal fluid, the clear fluid that bathes the brain. If we see that at surgery, there are different approaches, but I will usually pack the nose, sometimes using a piece of fat from the thigh, and I will usually leave a drain in the back, a lumbar drain, for a day or two. The other people do things differently, but I feel that's the most likely to quickly and definitively heal the problem. The focused radiation, very low risk, but again, never zero risk. Is there some risk of the focused radiation causing tumors or vision problems? Yes, but very, very low. And again, I think, a very, very safe modality. And the medicines themselves are also very low risk, very well tolerated. So, in summary, pituitary tumors that are symptomatic and require treatment are uncommon, but we do see them. We have a lot of good treatments for them, and the outlook is very encouraging, particularly in the hands of experts and people who are treating a lot of these. Thank you.